Good morning, everyone. Welcome to this presentation. Is by Dr. Ellen G. Denton. The topic is suicide prevention training. Yes, and Dr. Denton is associate professor of College of Staten Island, City University of New York, in the state of New York, U.S. She's also the associate professor at University of Manchester Medical Center. Dr. Denton is a clinical psychologist with extensive experience providing psychological consultation service in Guyana since 2014, and especially to service providers of the orphanage population. She has a strong foundation in conducting training and mentoring, which has contributed to building suicide prevention clinical research capacity in resource-limited settings. Dr. Denton is the co-investigator on the Guyana Wellbeing Studies and consultant to the Columbia University and University of Guyana Research in Injury and Trauma Training Discrete Program. Let's welcome Dr. Ellen Denton.
So, actually, before I get started, let me ask, who actually work in the emergency department? Anyone here? No. So I will spend the bulk of the presentation on how to address a clinical intervention for persons who are at risk. We're going to identify who is at risk, who's not at risk, what we say, how we follow up with them. We'll be very selective. And then towards the end, I will focus on what persons in the emergency department can do. So if we work in a hospital, I will get there towards the end, but I will start more general for professionals in the field, for interacting persons who are at risk for suicide, yeah? So overview, I'll first tell you about suicide as a public health concern, which many of you have heard already over and over again, so I'll go quickly there. Then I'll jump right into the suicide risk and defining the population that is at risk, who is high risk, who is not high risk. And then last, I will go into the role of suicide prevention and what that looks like. So as you know, suicide is a global health concern. It is growing and it is increasing. It is not only in South America, specifically Guyana or Suriname, but we're also seeing high suicide rate in Asia as well. And here on the x-axis, you have age. On the y-axis, you have suicide death. I'm going to have to re-poll. Come on in. So on the x-axis, you have age. On the y-axis, you have death. And as you can see here, as indicated by green, that suicide risk in low and middle income countries are more prevalent than in high income countries, which are indicated here by blue. Yeah? It's also peaking at ages 15 to 29. So while I will present on what to do for all ages, really my research has focused on young adults and emerging adults, and even preteen adolescents here in Guyana. And if anyone has any questions about that, I can get to that towards the end of the talk. So let me re-poll again. How many persons here are working in a hospital setting? Nice to see you. So I will get to what we're doing with patients who attempt suicide in a hospital setting at the end of the talk. For the bulk of the talk, I will focus on persons who are at risk and working with them as professionals today. So what do we have here? We have a figure, and this came out last year, and it was during the pandemic while people were still locked down. What did we see? We saw, as indicated on the x-axis, which are weeks, we saw that the proportion of mental health presentations to the emergency department skyrocketed among adolescents if you compare the 2019, which is the blue solid line, to 2020, which is the dotted line. So you can see that we had not anticipated. And of course, what happened in 2020, it was the pandemic. So young persons were presenting to the emergency department, overwhelmingly so, and hence the title of this talk, how we want to better equip persons who work in the emergency department, all staff in the emergency department, to meet this overwhelming demand, yeah? Everyone wants to know the question and wants to answer the question, so what happened? Did the COVID pandemic increase suicidality and hospital presentation? Anyone have any thoughts? Any people who say yes, that COVID made suicide worse? Yeah? Oh, majority worse. Okay. So we know that, again, prior slides showed that mental health issues skyrocketed and more people were presented to the emergency department. However, the data is showing that if we compare post-death pandemic rates of hospitalization for suicide to pre-pandemic rates of hospitalization for suicide, that there has not been any significant change. That in fact, people might have not been working as rigorously as back and forth work. Students were not in school physically, and so those demands may have contributed to this data. We don't know those answers, but there is evidence to show that mortality remained the same pre-pandemic versus non-pandemic, mortality across all risks of mortality, but suicidality, hospitalization did not change. Now, there was a slight caveat. We saw moderated effects, that we did see higher risk if we were compare 2019 to 2020. We did see a higher risk among 14 to 17-year-olds for accidental overdose and engaging in substance use. This data is from the States. So we don't have any conclusions as of now as to, are we worse off, better off with suicide risk? We know that suicide risk among youth has been increasing globally, and we're seeing this by not only different races and ethnicities and demographic factors in the States. Native Americans, we see among Black Americans, Black adolescents are at increased risk for suicide now. But it's a global problem, and we have not yet made, or so far the literature has not determined whether COVID-19 is a contributing factor to increase suicide risk. That has not been confirmed. So the question pertinent for all persons in this talk is, well then, who is at risk? We don't want to, I want to move us away from it's because of COVID-19, because that has not been determined, right? We do know that persons are presenting with increased risk to the emergency departments. Now we'll speak to my wonderful doctors in just a moment. But before that, let's just figure out who is at risk surrounding us. The persons who are at risk that are around us, surrounding us, are those who are not identified, those people who are undetected to be at risk, those people like those who've had a suicidal thought or suicidal wish, and no one knows because that has not been expressed. The other person who's at risk are people who had past suicidal behaviors that you might be unaware, and the people who are disconnected socially that, again, you might be unaware of. Another person who is at risk are people who are without access to care. So those people who have no regular doctor, have no regular primary care physician, that they have no regular resource in which they can interact and discuss their mental health and their mental health status. There are also people who are without clinical services, those persons who are unable to manage stress in their life, and those people who not have follow-up connections. Let me just emphasize a point here. Without follow-up connections and personalized treatment care tends to be something that we easily overlook and we kind of accept. For those who are working in the emergency department setting, we know that after a person is suicide, there's a 50% likelihood that they'll never even when you try and reach out to them and you're trying to remain in contact, it's almost like, where did this person go? 15% of them are going to be not compliant with what their physician prescribed. So when we look at no follow-up connections, we're also not accepting that as just a part of the system and a part of care. It's also considering that this is placing them at increased risk for suicide. Yeah? Who else is at risk? Well, there was this big study that came out around 13 reasons why. Anyone familiar with that Netflix show? Yes, I've seen the younger persons. Thank you for representing. So there is a show of those, of 13 Reasons Why, that came out on Netflix. And it chronicled Hannah, our person's life, and what led to her suicidal behavior. It was quite explicit. And there was this is a great study by Dr. Thomas. There was a great study that was published in JAMA, which is the Journal of American Medical Association, that they tracked and monitored the tweets and the Instagram notices as a proxy to how much young persons paid attention to the show. And the question was, looking at the amount of tweets that these young persons had on the show, because that's the proxy for how much they paid attention to expose the learning about ways to harm themselves, was that going to be associated with suicidal behavior? How many people think that it was associated? You think being exposed was associated? Yeah. So said, so done. With over, and you can see here, they compared April 2017, that's when the show came out, to June 2017 data. Over those 3 months, they were able to see that there was an increase among males, there was an increased mortality from suicide among males and females, particularly in the younger age groups. So who is at risk? Those who are exposed, who have ways or thoughts of how to harm themselves in their mind. And who is that? Those are young persons who have YouTube, who have Netflix, because by that, they can learn, and all of us, because we all have access, they can learn ways to complete or carry out a plan without considering how lethal that plan is. And that's a totally different question. And I'll get to that for our clinical persons in the audience. But who is at risk? Those who are exposed to means and exposed to ways to die by suicide. And that's a great article if you want to have a happy sentence. Who are the high-risk persons? So there's a difference between those who are at risk, and then there's a high-risk group. The high-risk group we're going to define as people who are in domestic violence or abusive situations in homes, those who have socioeconomic disadvantage and are unable to cope with the stresses of their life, maybe living in rural areas, and who do not have, who are not thinking through alternatives to their psychic pain and their aches. Several key persons, we all go through stressors and feel psychological distress, right? But we can, healthier persons will think through, well, it will be different this way, or I'm going to change, I'm going to interact with this person and connect with this person so I feel better that way. And they're going to put things in place. When we're not in that situation, then this is increased risk. Also, frontline essential workers are increased risk. Talk about burden and work. Youth are increased risk, and elderly. So, what do you want to do? Now that we've defined the population, who is at risk? There are people who are at risk and those who are at higher risk. What do you do? The first thing you need to do is to recognize the warning signs. Warning signs for suicide are persons who are speaking that they're expressing that they're hopeless, expressing that they want to escape and they just can't do this anymore. People who feel trapped and feel like they're experiencing an unbearable pain. If you hear such language or that's communicated, consider that a warning sign. Consider that as a warning sign to suicide. Also, if you see a change in behavior, increase ingestion of drugs, increased ingestion of alcohol. That's a change in behavior, that things are getting worse, and they're not using what we call pro-social ways to cope with it. Changes in sleep, changes in weight, changes in fatigue and aggression. I've often interacted with patients who had, in the hospital, who attempted suicide, who said things like, I haven't slept for 2, 3, 10 days. And that kind of physiological wear and tear on the body can certainly impede rational thinking and processing. Yeah. Also, persons who experience depression, anxiety, loss of interest, humiliation, or some sort of, sometimes you'll see like a lull, and they'll say, persons who are hopeless for say 2 weeks, and then all of a sudden they'll say, you know what, I'm fine, everything is great. If you see a sudden change like that, that can also be a warning sign. So what you want to do is pay attention to those types of warning signs. And then understand in your mind, does this person have a mental health problem? Am I aware of that? Does this person have access to pesticides, to hanging themselves? Do they have some sort of lethal means? Have they attempted suicide in the past that I know of? Are they exposed? Have they been watching things, or do they have a family member and they know of how someone died by suicide? These are all risk factors. And so you want to be asking yourself that question before you speak with them. Because your next step is to not burden them with all of your processing of the warning signs. That's for you. The next step for you then is to ask them, are you okay? Simple. Ask them, are you okay? And if you really think that suicide is something that they're grappling with, you use the clear, precise, and direct language. Have you ever had thoughts of suicide? And the posture in which you ask this question as a professional, the posture in which you ask this question is to get a clear answer of yes or no. No judgment, no preaching, no lecturing. You just want to know what's going on in their mind. And notice the word is ever. So the person could have had that thought of suicide 3 months ago, 6 months ago. You're not trying to diagnose them then and there. That's not your job. You want to make sure that since you've been processing these warning signs and you think something is up, you want them to hear your care for them and ask them, have you ever had thoughts of suicide? That's what you're doing. This is not, you're not playing doctor here. You are really just trying to understand what's going through their head, because it can often be quite kept, and it can be a private thing that they do express otherwise. So that is a contention, and I know, because so many persons are uncomfortable asking that question. Have you ever had thoughts of suicide? That's a direct question. There are passive ways of asking that question. You can say, have you ever wished you were dead? Or have you wished that you could go to sleep and not wake up? That's a passive, sometimes soft way of getting at the same thing. Depending on the age, and depending on the cognitive maturity of the person, you might not want to ask the passive ones. You want to be direct. And again, no judgment, no lecturing, not a lot of chitter-chatter around it. You just want to understand where they are and what their status is. The other problem between not only active and passive, the other thing is some people just don't feel comfortable, including clinicians, asking that question. They think that there will be an iatrogenic effect, and I will just tell you that that's a fancy way of saying, if I ask them, is it going to cause suicide? Is that going to be the problem? I don't want to do that. I don't want to mention the word suicide if it's going to make them want to engage in that behavior. So there was this great study done by a man who's also at Columbia. And this study looked at over 2,000 young persons, high school students in the state. And they put them into 2 groups. An experimental group where they asked them about their mood, and they also asked them about their, have you ever had thoughts of suicide? And then the control group were not asked about, have you ever had thoughts about suicide? And there are over 1,000 in each group, so they want to compare. Just asking about suicide place this group at a greater risk than the group who is not asked about suicide. So 2 days later, they followed up with these 2,000 students and that's what they found. There is no difference. So what do we infer from that? There's no difference. Whether we ask about suicide or not, it will not change someone's mood state. It will not. In fact, what it's going to do is inform us of their risk. And that's what we want to know. So we go on with that data to confirm that asking or not asking is not going to change their mood state. And in fact, I'll give you this one a little bit more from that study. That in fact, the persons who are young students in those high schools who had depression, what we call who had BDI scores, like depression inventory scores greater than 15, those kids actually had less depression when they were followed up in 2 days. So for the high-risk population, asking is actually beneficial. It made no difference for those who weren't at high risk, but for those who are high risk, it was actually beneficial. That's a great paper that should do today. Now, you might say, so first we're going to be direct. Two, we know that asking is what we need to be informed, and we need to understand who they are. So we're just going to ask them the question directly, knowing that it will not place them at any greater harm, according to the data. And it might even help someone who's at risk. And when you ask patients who are in the hospital, youth who are in the hospital with admitted for several different reasons, what do you think about nurses or other staff asking you about suicidal thoughts? Which most, over 81% of the youth respond that yes, I want to be asked. Why? Because they feel cared for, because they feel like this is something they would probably express with someone who asked them in the hospital that they couldn't express at home. Or also they said because when you're in the hospital, you're feeling physical pain, and that physical pain could be compounded and make matters worse, so isolated in the hospital. So if someone asks you, it's like, oh wow, you understand, I have physical pain, I have emotional pain, now you're asking me about it. So we have data to even show in the hospital that being asked by a clinician would actually help us welcome. So after you ask if you're okay, and you ask, have you ever had thoughts of suicide? The next step is not panic. You have to determine what risk that person is at. Remember, you did not ask them about their thoughts of suicide to diagnose them or to put them in a risk category. You just want to ask in their mind what is and how they're dealing at that point in time. You want to know if they're okay. And so you don't want to panic, and you want to follow up with the suicide screen that I will let you know of. Not all suicidal cases are an emergency, and that's quite important. Not all of them are. So, first suicide screen is called the ASK. And if you want the tool that is recommended to use as a screening tool for persons who are as young as 10 years, they've tested whether young persons as young as 10 years of age can answer this, and we know that they can. So you administer the ask. The ask simply says that if you want a website on how to upload it, I have one or two after I can use two characters. The ask is an NIMH tool that says, in the past few weeks, have you wished that you were dead? Yes or no? In the past few weeks, have you felt that you or your family would be better off if you were dead? Yes or no? In the past few weeks, have you been having thoughts about killing yourself? Have you ever tried to kill yourself? 4 questions. That's it. Yes or no? Remember, when you're asking these questions, it's non-judgmental. You're just trying to understand where they are. It does not have to be exact. I felt that way yesterday or today or 2 weeks ago, but I don't feel it this way. You just want to hear their response. Yes or no? And usually, it will come with a story, and you want to listen to that. Yeah? And then you're determining in your head, yes or no. They fall into those categories. If any of these are yes, or they refuse to answer, consider that a yes. If any of them are a yes, or if they refuse to answer, you consider that a yes. And you have to then follow up with an acuity question. That acuity question is, are you having thoughts of killing yourself right now? People can say yes to all of those and not have thoughts of killing themselves right now. Suicidal risk is transient. It changes moment by moment. And the expression and communication of that risk is complicated. And so if they don't feel that they can explain their situation at that moment, then they won't do that, and they might deny that they are at risk right now. So you take and you hear their response, they're not at risk right now. If they are at risk right now and they say yes, this is when we're going to move on to a brief suicide safety assessment. This is when it moves out of the I'm a caring person, I'm a caring professional, and you probably need to consult someone who is trained or certified to do a safety assessment. This tool is also free. The brief suicide assessment is also free. And what's nice about it, it tells you the exact script that you need to speak to that person. So at that point, remember, a person said yes to at least one of those 4 questions, and they said yes to right now, I'm having thoughts, right? At that point, you have a script. I'm here to follow up on your response to the suicide risk screening questions. These are hard things to talk about. Thank you for telling me. I need to ask you a few more questions. So you have the exact words. And then you can go down. And what you're doing is assessing symptomatology. You're assessing their, if they're at imminent risk. You're assessing if they're at a moderate risk, or if they're at a low risk. And there are different responses for each of those. So again, hopefully I am breaking up for you how to think about suicide risk. Not everyone is going to be in that high risk group. And not everyone is going to be at moderate risk. Some people are going to be at low risk, and you won't even have to stay with them. But there are things that you can do, like safety planning, and they can follow up with someone who's a provider, who's a professional expert with this. Yeah. So after you perform, or the professional, someone who's certified or trained, performs a brief suicide safety assessment, and note, this only takes 10 to 15 minutes to do. The words are printed here. Then you want to move into safety planning with them. This can happen both in the emergency department, and this can also happen outside in the outpatient setting. You want to go to show what is the plan. Is there a plan? A person who has a plan to die by suicide is at a different or increased risk if they have a very intricate plan and they've thought through this. That means they've had this in their mind and they've thought through it. And learning about that plan is very important. And what you want to do as you learn about that plan, this is another handout that you need to go through, yeah? What you want to do in learning about that plan is to be able to have a conversation with them about what signs do they recognize in themselves that place them at risk. So some people, earlier we had a comment about bipolar disorder in the room. Some people might be in a manic state or a hypomanic state and not even know that they're in a hypomanic state. What I mean, that's very clinical. Some persons might have not slept for days, and just say, my sleeping is bad. Or their loved ones around them might just not take it for anything. And that could be a symptom of a hypomanic state. They were not aware of that warning sign, yeah? Some persons might have been looking at ways to purchase ribosome or some sort of, and they went and looked in the cupboard and know exactly where it is and have been toying with it and looking at it, and they haven't expressed that with someone. and they don't recognize that as their own warning signs. So at that point, when you're safety planning, you're going through what are the warning signs that they are aware of to know how severe their suicide risk is. Any questions on that? And I went through that quickly.
This one question. I've been bipolar disorder for 20 years. I've had several episodes that cause hospitalization. My question to you is, when should the doctor or person intervening ask these questions? Because I'm thinking you should ask if you observe something, if you notice a mood change, like a change in mood or actions.
Okay.
That's what.
That is a great, I'm going to summarize that towards the end. And so hold on to that, and hopefully I'll answer it. Let me know after if I do not. Thank you for that. You're right. You're right. So you want, when you're safety planning, you're wanting the person to identify their own warning signs. You're also talking with them and talking about ways to cope. And so here on the safety plan, the step 2, this area here is talking about things that I can do to take my mind off my problems without contacting another person. So what are the things that they are going to do? Oh, I like to go for a jog. Oh, I like to talk with my best friend, blah, 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 blah. And so these are things that they can do actually that's without another person, without someone having to be with them and be their guide. You want them to identify those things and list them. The next step is people in social settings that provide a distraction. This is quite important because this gets in on anhedonic symptoms, which the clinicians know here. People and connectiveness, and I'll go back to this, it's powerful how interaction, real, authentic interaction with another. How many persons here have had a real good conversation sometime? Now you feel after a real good conversation with someone, that can diffuse so much stress and strain. Not every conversation is good, we all know that. But if you experience a true connection with someone, it can diffuse a lot. And so you want to help that person identify people in their life who would actually bring about such an exchange. Also, social settings that do that. You know, I noticed that I've had many suicidal patients say, whenever I'm around my children, whenever I get in the living room and they're just yapping and laughing and carrying on, yeah, I don't think about it. I don't think about wanting to die. So that gives the person control, and we want to do that. That's those self-efficacy, which are psychological principles that we want to encourage. That gives that person control over to place themselves in situations and with people that will have those thoughts of suicide. Yeah? So first, we want them to recognize their own warning signs. Second, we want them to figure out with them. You're talking with them. This is a engaging conversation. What are the ways that you cope without others? And what are the ways that you cope with people and social settings that actually distract you from suicide? Then the next step, step 4, is you go through, you find people who they can ask for help. Not everyone, not everyone is going to be the help, and that's good. That's healthy. You want them to say things like, oh, I have a doctor who I haven't spoken to in X amount of time. I can tell them anything. Oh, I have a so-and-so, and I can actually communicate what I'm going through with that person. And so you have a line here for 3 persons and names. If there are more, you can do that. The next step, step 5, is to identify the emergency contact. Should the severity of the risk escalate, how likely are you to engage in this behavior? Because remember, they told you that they didn't have a plan, right? How likely are you to engage in this behavior? And they say, you know what, doc? Or I'm a 9 out of 10. I really want to do this. What are the emergency responses? I'm going to give the name of the national hotline here, and that would go right here on this name. Our RHO that's nearby, that will go right, a regional health officer, yeah. That will go right on the line. Whomever the emergency contact is, then you write them down. This is going to go with the person who you're engaging with, and this is what we call their safety plan. So they have the emergency contacts, they have people who they know that they can ask for help, these are trusted, connected people. They have people and social settings that distract them from the thoughts of suicide. They also have internal things that they can do to cope, puzzle, book, or whatever. And they are aware of their own personal warning signs, so they can monitor how severe their suicidal thoughts are. The last two steps are actually really important, especially for Diana. The last step is, how do I make my environment safe? After you've gone through all of this safety planning with the individual, that environment has to be very safe. And having access to pesticides, knowing where to go, which road they were going, walking traffic, if that's what they're thinking of, is not keeping their environment safe. Means restriction, there was an article published in the Lancet, actually in 2022, Dr. Shaw did a systematic review on studies that were done here in Guyana. And a systematic review is study of studies. For those who were here earlier, Dr. Brandis taught us that. So a systematic review done here in Guyana by Dr. Shaw, published in Lancet, summarized that in Guyana, restricting people's access to pesticides are key to keeping people safe. So in this safety plan, this last step, you want to make the environment safe. And the way you're going to make the environment safe, it means take away knives, take away the Clorox, take away, that's what you do. It can go to another house, you'll work through it with the person. How are you going to make that environment safe? They should not have access to it. Lastly, you want to ask them, tell me one thing that is important to me and why your life is worth living. Tell me one thing that is important. To you, and why your life is worth living. This is a very important question. Reasons for Living says to account for over 70% of patients who have attempted suicide and have not attempted it again, because they have a reason for it. And being able to say that and express that to someone is powerful. Being able to express that to someone who can contain it and take it is powerful. They don't have to contract. You want them to just be able to state it and hold it. That's the safety plan. Yes? So let me go back, and I'll go quickly because I know I only have 15 minutes, and I promised our emergency department people that I will get to them. So you want to listen and offer help, and you want to make that safety plan. Remember, you went through the warning signs and you processed that on your own. You want to ask them if they're okay, and then directly, have you ever had thoughts of suicide? Next, you don't want to panic. Not every suicide is an emergency. You want to do the screen. If they have one of those 4 questions are a yes, and they are actively at risk, then you need someone who's certified and trained to go and do a more thorough 10 to 15 minute or so assessment. If they are imminent risk, they need to go probably to the hospital. If they're not at imminent risk, then or if they're low risk, you do a safety plan. If they're moderate risk, you do a safety plan, and they should be following up with all of those referrals that were listed. Yes? You want to be non-judgmental, and you want to help them tackle a system that might be hard for them. You don't want to be dramatic, act shocked. You don't want to lecture them about heaven or hell. You just want to meet them where they are. And I can go through that, but we don't have time. I'm happy to share the slides afterwards. The emergency contact here in Guyana is 223-0009 and 223-0001. These are resources that, again, I can make that available to you. These are resources that you can go to, and it gives you language on how to have these conversations with people. So that's for most of us. For those who are in an emergency department, this past year I worked at University of Rochester Medical Center, where I engaged over 250 prisons after their suicide attempt. And we offer them a 3-session therapy. It's called OSIP. It was 80% effective in Europe at reducing a future suicide attempt. And so we gave them this therapy to test to see if it would reduce a future hospitalization within the next 3 to 6 months. The trial is ongoing, but I want you to know the therapy. So I will expose that to you. Just how do I prove it? This is for clinicians now. This is after a patient has attempted suicide.
After I survived 2 suicide attempts, I didn't know what kind of treatment I should look for. Part of me wanted to just not talk about it, just get me out of this hospital. Now, years later, I'm dedicated to helping others find options that will help them recover so that they can have a full life. For me, one step was finding the right treatment. There's a new option that can help you take that first step, called ASIP.
ASIP stands for Attempted Suicide Short Intervention Program. This is a person-centered treatment especially designed for people who attempted suicide.
Early research is very promising. In one study, people who had participated in ASIP had 80% fewer suicide attempts than those who didn't. We need to know more, but these results were impressive for such a brief therapy.
The second S in ASIP stands for short, and it is. You can complete this treatment in just 3 sessions.
In the first session, you share your story and capture it in video form.
In session 1, we meet together and have a videotaped narrative interview of the story behind your suicide crisis.
Something like, behind every suicide attempt, there's a story. Please tell me your story. And I just try to sit back and listen and let someone tell their story as completely as they can, and be there with them.
The second session allows you to see your story from a different perspective.
The second session is devoted entirely to watching the video playback. So we sit down in front of the screen and I introduce it by just asking them if they've had any thoughts or feelings, emotions. The first session, any thoughts about what went on, and then invite them to watch the video, and we stop at different points to look at where there might be more questions, or there's some total themes that are coming up. So really looking specifically at suicidality and what led them to the suicide attempt.
In my opinion, that is very powerful. Being able to see what my story is.
In the third and final session, you develop a custom plan with your therapist.
I listened to their story in the first session, reviewed it with them in the second session, so now I try to, in a first-person voice, bring together the different factors that led to their suicide attempt and being in that state of mind. Then we review that together for them to offering feedback, corrections, thoughts.
And then finally, we bring everything together and put it into a safety plan that includes some of the warning signs to be on the lookout for suicidal crisis in the future, as well as strategies to help both in the long term and in the immediate address those concerns, and also a list of people to contact for help in the future.
There is a lot of nervousness about starting the therapy, and that is understandable. Who wants to be videotaped? I'm nervous about being videotaped myself, but that videotaping process is likely the greatest strength of us.
That's awesome. Just 3 sessions. Share your story, see your story, develop a plan together.
ASIP is not the only option for hope after a suicide attempt, and researchers are still learning about how it works. But I can tell you this, I wish ASIP had been around when I was first recovering. Whether you receive ASIP or not, I want you to know that I made it, and so have many others, and you can too. It's your story, and you make the change.
If you're interested in knowing what the next steps are for ASIP or want more information, talk with your treatment team or the person who shared this video with you.
So as I explained to you, this is a 3-session therapy. That's for doctors or clinicians after the suicide attempt who are treating a patient. And we can talk more about the resources to do that. One of those resources that you use, Dr. Tony Asani, his contact information is there. Anya would have to come and do training and such, but that is an option for doctors who work at PhD if they are interested in such a 3-session therapy. Again, that's a therapy for clinicians and providers who are treating these patients. Also, in the emergency department, there's opportunity to apply that safety plan and restrict the means, and also restrict means to alcohol and certain substances that are dangerous. That is also working quite well. It hasn't been tested yet, similar to Austin in the States, to confirm, but there's promise in this intervention to restrict means access and also substance access for persons who are using substances or maybe abusing substances or engaging in risky behaviors with the using substances. Last, I want to tell you all, and then I want to take questions. Safety plan will talk about that. We want to emphasize the importance of connection. This is a great study, Carter et al., where they looked at veterans, people who have served and who are at risk for suicide. And what they did is they stayed in contact with them with a letter. They had a session with a therapist, and that clinician, they went through not only safety, but they also had treatment for whatever disorder that was being addressed. And what they did is they sent them letters to follow up at 3 months, 6 months, 9 months, 6 years. And persons who received the letters versus those who did not had almost a tenfold lesser chance of harm by suicide, death by suicide. That's huge. Connectedness is key. So if our persons, whether they're high risk or low risk, we all need connection. And I want to leave you there with knowing how to engage and to connect with other people. That can actually literally save a life. So you might not be the doctor who's giving them OSIP therapy, that's fine. Or you might not be the one who is doing the complete safety plan. Or even the person who's doing the suicide safety assessment, the BSSA, that was the second form that I showed you. You might not be that person, but you are a person who connected another life. And that is key. So I leave with you, resign your rights, when you want to lecture someone and tell them about themselves, and just connect with them. Thank you so much for your time. I'm open for questions.
The things that you're supposed to do. I just want to get a good picture of it.
Wait, first, you go first.
I have a question.
Oh.
I just wanted to see the slide with the things that you said to talk about.
Yes.
The whole long list.
Okay. Yeah. So yes, did I address some of your questions?
Not total in a total way. Yes. So, my way of dealing with questioning is in a different way. One, by asking of the person's mood, activity, and your observation. You understand? Because the mood, are you depressed? Are you happy? Activity, are you overactive? You're very active, or know if they're manic, or if they're reducing their activity, maybe because of depression. They just want to stay there. They don't want to be active. And then, no, I'm just saying that's why.
Yeah. Well, thank you. And I just then want to say that he said that he would address their mood and their activity. That is a part of the suicide safety assessment. That's the next step after the screening in the observation. So thank you for that. Are there any other questions?
My question is, mothers who are diagnosed with postpartum depression, before the delivery or the birth, if there's an assessment where clinical or professional can diagnose a mother before giving birth, knowing that the person is going through postpartum depression and a detachment from baby, from birth, from the womb.
Thank you for that. Postpartum, yes. So that is, if a mother knows that she might be struggling with that, that is a part of a visit, a wellness visit for pregnant women. And so hopefully that will be known before they give birth. In fact, suicide risks in certain settings, they will start with depression before going to next imminent suicide. So some of these screens, I know I showed you the suicide screen, but sometimes they give what they call PHQ-9, which is called the Patient Health Questionnaire 9. And depression, the 9th question is about suicide, thoughts about death. But before that, they're looking at their mood and they're assessing how depressed they are. That would be a part of the assessment for the women before birth, yes? The monitoring and following after birth would be key. And the referrals for that mom after birth are going to be key for their provider and their treatment team. Does that answer your question? And thank you for mentioning that, because depression, I didn't speak about the depression screens, but depression screens are a way to get to the suicide because it can be a charged question.
And especially with regards to young people who may be having confusion. I didn't see that picture, I'm sure, but there are times when sometimes bullying and stigmatization is very information toward that. I was wondering if there's two that you can use to do that.
Yes, thank you for that question. So, I see we have a question online. So on the suicide, Columbia's, this tool that, the safety plan tool, looks specifically at coping strategies, internal coping strategies as well as external. And bullying is a risk to suicide, so I'm glad that you mentioned that. Peer bullying can be a significant stressor to the point where young persons might want to avoid going to school or certain interaction. That is definitely a risk. What we want to do is equip those young persons on how to respond and one, to such threats. 2, get all of their allies. And they have to know who their allies are and know how to use their allies, yeah? And so what we want to avoid in that case, whether there's gender identity communication that needs to be done or not, what we don't want is for them to hold it and for it to fester and they to be alone with that difficulty. They're being bullied, we have to equip them on how to respond and help them use their allies. Number is step 2 and 3 on the safety plan. Yeah.
Really, what would you say is a major reason behind attempted suicide or suicide among secondary school children? And how would you say the government can help the children to cope with that suicide?
How to help them cope with suicide in general? Yeah, thank you for that. That was a big question. Why are young adolescents facing suicide? It's complicated, it's like two responses. I think that when we're seeing the rise, there's several things that are occurring. When we're seeing the rise on suicide globally, is that one, I think that young persons have feigned relationships. I said connectedness is key. And relationship skill is developed first in the home, and then it goes externally. So if we're developing those skills, hopefully young persons are truly developing those skills from the people who are surrounding them. And if those persons are absent, like mother and father, or auntie or whomever those key people are in their life, if they are absent, then that's a knock against their relational skill development. It doesn't mean all things are lost. It just means that they're not developing the skills or relying on those people who they need truly to develop those skills. And then as they go on, depending on how mature or immature, because there's a range, their interactions are on the internet. They might think that they have friendships, and they don't. So that realization, and I'm just speaking to more novel issues that we are facing in our current society. So I think that that is a huge attack on our young persons that probably people who were born before 1990 did not have to undergo, honestly. So it's up to us, those who were born before 1990, to help our young persons. I'm also biased because I'm a success specialist, but we have to help them to develop and cultivate those skills so that they can have connection that can buffer the ails and the blows that life will come with. I think that's one. I also think that exposures are key. As I said, for those people who were born, this is true. Before 1990, I mean, the most we saw was Superman going up with his lift. Like, we didn't see anything on TV. We saw nothing. Okay, I mean, the animations that we saw were far, far more innocent, I think. We did not see homicide. We did not see, I mean, we just weren't exposed to that level of graphic. And now we can get graphics of things that are just so startling. Someone will just forward a message. Don't be that person. Don't forward a message of a man broken limbs rolling around in front of you. Right? That's just traumatizing. You'll have a nightmare. No more. So I think exposure is another thing that is different. And I'm just speaking to clinical. We do know the regular clinical risk factors, such as mental illness, psychopathology is certainly a risk factor. We do know that hopelessness in and of itself is a risk factor. Symptoms like impulsivity, we know those things, and that has always been. And those are also contributing to suicidal risk. So I'm sorry, that's a broad answer, but the depression, the anxiety, the mood disorder, a previous attempt, exposure to attempt, I can go on, bullying, stigmatization, all of these things are contributing to the risk. And what can the government do? Hopefully, this talk was focused on the individual and the persons in the individual's life. So hopefully I will communicate the message of that there's a lot that we can. I don't know what the government here per se can do, or what the U.S. government or anyone else, but there's a lot that we can do. Thank you. I know that it's time and it's lunchtime. Who would want to keep from that? For those people who are interested in those handouts, I'm happy to give it to you. I appreciate your attention.